Well, good afternoon, everybody. It is 1 o'clock, and we just have a little bit of time left together. Really pleased to welcome DHCS Director Jennifer Kent to the stage, along with CHCF's Chris Perrone. We're going to try something a little bit different for this final panel. Sorry to disappoint some of you, but there will not be any PowerPoint, and there actually won't be anyone standing up here talking at you. What we'll do is we've structured an informal dialogue among the three of us. We will take questions from the audience at the end. We'll aim for about 20 or 25 minutes of questions. So as we're talking, please do take note of any questions that you do have. And on that note, I'll start the group off with the first question. And I would direct this first to Jennifer and then to Chris. Jennifer, could you share with us sort of at a broad level maybe your top three priorities or issues that you think the Medi-Cal program will need to focus on in the coming 1 to 3 years?
Great, thanks. Aside from the goal of just surviving day to day, sure. So as you heard from the previous panels, we do a lot of really important work in the department. We have a lot of really creative ways that we try to get services to beneficiaries. We have a lot of things that we do in partnership with the counties and the legislature and the federal government. But on any given day, the fact I still continue to be amazed that there are women out there that get pregnant and need maternity services and eventually need to deliver a baby, and they do all of that, and we somehow pay the hospital, and the mom goes home with a baby, and everything kind of works out, and all's good. I'm still fundamentally surprised that we actually managed to do that with the success that we do. And then you talk about much more complicated things within the department. When you talk about kind of the top three things that I have been either focused on or continue to focus on, one of which is making sure that we as a department are always mindful of the fact that we have a lot of people that rely on us for services. And so what are we doing on any given day to make sure that we are trying to make our program as either accessible or as functional as possible? Sometimes it's not all that interesting or headline grabbing to say that I just want my department to function as a program. But that's really actually a really important thing for us, is that when we scramble something, and believe me, we do it, it impacts someone at a very personal and real level. And so we have tried really hard over the last few years to take a breath, enjoy the fact that we have good economic circumstances and that our state has the funding to be able to fully support the program, and we're not in a place where we're cutting the budget. But really to focus on, are we contracting with the right people? Are we doing the right oversight and monitoring? Are we making sure that the services that we are delivering down at the ground patient level, are they the right services, and are we getting the right outcomes for that? There's a lot that can be said for making sure that processes are both appropriate, not too overly cumbersome when possible, and that we're being transparent with both our stakeholders as well as the federal government and policymakers. Another item that has been really important to me is the continued integration of behavioral health into the larger program. So when I started in 2015, we had just as a department absorbed 4 other state agencies. So Department of Mental Health, Alcohol and Drug, California Medical Assistance Commission, and the Managed Risk Medical Insurance Board. On any given year, the absorption of a single agency is a significant organizational undertaking, and the fact that we did 4 over the course of 2 years was really both disruptive from an organizational standpoint, but also has continued to kind of evolve as we have looked at what we have done with those programs. We've looked at the behavioral health and the need to have behavioral health more closely aligned with the rest of the program. So more on that in terms of function and vision for what that looks like going forward. And then lastly, I think that we are always wanting to be innovative when it comes to how we both finance and deliver services. A couple of things in our waiver, the dental transformation initiative didn't get mentioned earlier, but there are certain things that happen in our program either through a series of policy initiatives or public interest. And I know that the dental program, when I started in 2015, was something that was driving a lot of conversation around our kids getting the right kinds of services, as utilization where it needs to be. And it's taken 4 years of a lot of intensive effort on our part. There have been internal changes to the organization. There have been external changes in terms of additional funding provided both by the state and the federal government. When we were negotiating the 1115 waiver in 2015, we couldn't get everything that we wanted, but we had a little pot of money, little in my world, $750 million. And Mary and I were sitting across the table from each other, and we were on the phone with CMS, and basically they were like, this is what you can have. And we're putting the phone on mute, and she's like, dental? And I'm like, dental. And those are the ways in which decisions get made around what do we want to focus on as a department. But the Dental Transformation Initiative and how that has been more innovative, working with providers and local communities, continues to be a goal of ours in terms of how can we make this program both stable as well as try to do things in a slightly different way that either deliver better services, ease burdens on providers, or simply get better data and transparency so that we can make better policy decisions around how we run the program.
That's great. Chris, do you have, what are your top three, Chris, your top three issues for Medi-Cal going forward?
Sure. Well, I will preface this with particularly since I'm up here on the dais with Jennifer. I'm a former state Medicaid official and have the greatest respect for the folks who run and operate the Medi-Cal program on a daily basis. They really do an amazing job, and the public service that they bring to work every day is truly something to behold and to appreciate. And so when I think about the priorities for Medi-Cal, I think it's important to recognize that these aren't just priorities for DHCS. This isn't about finger pointing, oh, you should do this. Jen, I'm sure, gets plenty of the you should do this. This really is a shared responsibility. And when we went out and talked with stakeholders about 2 years ago about a vision for Medi-Cal, that's one of the things that came out of those discussions, is that improving the Medi-Cal program really is a shared responsibility. So whether you're working at the department, or whether you're working at a healthcare foundation, or you're working in the delivery system at a public hospital or private hospital or an FQHC, whether you're working in the counties, whether you're working in the legislature, this really is incumbent upon us to all work together. So just with that as a way of sort of prefacing, when I think about the challenges, some of the key challenges to solve at sort of a high level, I start with the problem of access. That's probably not a surprise. I'm the Director of Improving Access at the California Healthcare Foundation, so I think it's my obligation to start with access. But it really does start there. There is a federal law about equal access to care for Medicaid enrollees nationally, and we're not meeting that. When you look at the experience of enrollees and how they experience access, we find important gaps between their level of access. Medi-Cal enrollees are twice as likely to report difficulty finding a physician. Those with chronic conditions are four times more likely to use an ER as their primary source of care as those with other insurance. So there's big gaps there that we need to address. I think it starts with provider participation in the program. The studies that we've done on provider participation in the Medi-Cal program show that there are far too few providers participating, or there may be enough providers participating, but the level of participation is too low. So if you're just counting how many people are participating, you're fine. But if you actually look at how much time they're spending with Medi-Cal enrollees as opposed to other parts of their practice, the amount that you get is too few to serve the enrolled population, and not enough even to meet the department's own standards. So I start with access. I then go to quality of care. And I think the department is really to be applauded for their Medi-Cal managed care performance dashboard, which really builds up a lot of the data that they get from other reports, including the health plan quality data, HEDIS data, the consumer assessment data, CAHPS. And when you look closely at those data, what you find is that the beneficiary experience varies depending on what plan you're in. It varies depending on whether if you're in sicker health, if you speak a language other than English, you have a harder time getting the recommended care that you're supposed to be receiving. If you're in San Francisco Health Plan, as opposed to HealthNet in San Diego, you're twice as likely to get some recommended preventive care, in particular cervical cancer screening if you're a woman. If you're in San Francisco Health Plan as opposed to Alameda Alliance, just 4.5 miles across the bridge, you're twice as likely to get some recommended care across a number of different measures. But the problems aren't just regional. Even when we look within counties, there's big disparities in the level of quality of care. So I think there's really an opportunity to raise the level of performance so that the experience of Medi-Cal beneficiaries is more uniform, and it's not only uniform within the program, but it is equal to that of those who have other sources of coverage. And then since you gave me three, the third I would add is the financial health of the program. And this is something that Jen touched on. It's something that Scott touched on earlier. Very complicated set of financing for the program. I'm very mindful, as I think as some of you are, is the fact that we've got the baby boom population has started turning 65. They'll start turning 75 in just 10 years. Our population of people over age 65 will increase by 50% just in the next 10 years. Many of them will rely on Medi-Cal, particularly as they get older and need more long-term care. That's going to put pressure on the program. So solving the financial challenges of Medi-Cal, even while watching our backs, meaning the recessionary issues that Scott raised, I think is an important priority.
We've got a lot there to dig into. One of the things that jumped out in what you said, Jen, was the importance of behavioral health. And we heard a lot from JC this morning about just how complicated that is. Can you talk a little bit about your vision, or in an ideal situation or system, what would that look like?
Well, I think also I think it was Deb Kelch's point this morning, the program, when it was built in 1965, trending all the way up to where we are today, there are a series of decisions that were made by policymakers and the department and the administration across multiple generations that were historical in nature, and that I am the direct administrator of those decisions. And so the realignment decisions of both 91 and 2011 cannot be understated in terms of the importance for what that means for behavioral health and how we deliver services as a state. Both of those realignment decisions, far broader than just behavioral health. They encompass CalWORKs, they encompass trial courts, they encompass public safety, local tax revenues, things like that. The nature of why those realignments occurred are also complicated and have a long historical genesis. But what that has brought to us is a enshrined responsibility for the counties to deliver both mental health and SUD services at the county level, along with a constitutionally protected financing source. And so, constitutions are kind of tough to change. You can change them, but they do require an extraordinary level of change. So if I was building a system from scratch, would I build it that way? No. But I do administer the program the way it is encompassed now. I think when I look at our future going forward in terms of the nature of both the 1915 and the 1115 renewal, we, in our earliest thinking within the department, are seeing that both of these waiver renewals offer opportunity for them to piggyback on each other, in that we have done some behavioral health work in the 1115 waiver around like whole person care, for example. A lot of those populations have behavioral health needs, and the services that we're delivering through the whole person care pilot are certainly addressing and helping with some of those needs. And then likewise, the 1915 waiver for specialty mental health services, there are ways in which we think we can more closely require county mental health plans to work more closely with our Medi-Cal managed care plans, which sometimes have a good relationship, but sometimes don't have as good a relationship as we would like, in terms of they're not aligned in terms of managing the benefits for individuals, or they don't, if they were to provide intensive services to that population, they don't actually receive any of the benefit of that work. So I think there's a lot of early and initial thinking for how we will both, within the structure of the financing arrangements that we have in the state via the Constitution, how can we push some of these delivery systems a little bit more closely together? And then, lastly to that is we're also internally reorganizing ourselves as a department. So we today shared with our staff internal to the department that we're reorganizing the mental health and SUD divisions. And we are not only putting them together and calling them behavioral health, but we are also kind of putting functions back in and kind of integrating some of those department, wide responsibilities back where they should be. And so when I look kind of forward on behavioral health, I am hoping that we will have providers in whichever delivery system they're in, managed care, fee-for-service, specialty mental health, or otherwise, that when patients show up at their doorstep looking for care, that we recognize that the individual is fully integrated, meaning they have all their issues and needs with them when they come to seek care, and that our delivery systems have been either changed or modified in such a way that we are better able to meet them at the place of need.
There was a lot there, and you unpacked it really No, you unpacked it so nicely, is what I'm saying.
I tried to get the Constitution in there, too, in case people were missing it.
You also mentioned financial incentives, which is, I'll return to this in a moment, but before we get there, Chris, in your remarks, you noted when we look at some of the data, we see variability among the performance in managed care plans. Maybe for someone just coming to the program for the first time, they look at the map that JC puts up on the screen and they say, wow, there's a lot of different models. What do we know about how those different models are performing? Is the first question. And then the second question is, given the variability that we see geographically, what are some of the levers that DHCS or the legislature or some of the other stakeholders that you identified in the beginning have to try to lift all boats?
So I'm going to ask you to repeat the second question after I answer the first one. But in terms of the different models, a couple things come to mind. One is we don't know nearly enough, given that we've had these models for since the mid-90s, really, and some of them date back much earlier than that. We don't know nearly enough about the different models and how well they perform. And some of that is some of that has to do with how we implemented this. So this wasn't implemented as a learning experiment. Counties weren't randomized in terms of the different models they had. So, to the extent that we see on average the quality scores of county organized health systems higher than they are for the local initiatives and the commercial plans, is that because that's a better model, or is that because the counties that adopted the county organized health system have something integral in their fabric that says, hey, we want to take responsibility for this population, and it's that DNA that leads to higher quality, that if you tried to transplant that model to another county, it wouldn't work. We don't know that. And absent an experimental design, we're probably not going to know that for sure. But there certainly is much more I think we can tease out in terms of some of these models. But more importantly than the model itself, I think is we can do a better job making all the models or each of the models work better, each of the plans work better. So within each model type, and I'm just going to talk about sort of the three major types, the county organized health systems, the local initiatives, and the commercial plans, you see lots of variability, right? Kaiser Health Plan is a commercial plan. It has off the charts the highest quality scores compared to other plans. Now, some of that is their membership, because of the way their enrollment into Kaiser works, is a bit different than the other plans. Maybe that's some of it. But nevertheless, I think that's something you can see big variation within the commercial plans. Similarly, there's big variation within the county organized health systems and the local initiatives. So it's, aside from the which model works best, how do we get all the models, or each of the models, working better? And I think there are a number of things that we can do there. You know, it starts with better data. The state has really undertaken a heroic effort to get better data about provider networks within its managed care plans. I think we still have a ways to go to make that data useful. I think the data that I've seen anyways, I think is a bit, presents a bit of a rosy scenario in terms of our network adequacy. So I think we really need to understand, again, to the issue I described earlier, that when a provider is part of a network and participating in a health plan, is that 10% of their time or is it 100% of their time? Because it makes a big difference. Are they working with just one plan, or in San Diego, are they working with all 7 plans? So those kinds of things, just really getting better data matters. And then, and I can spend more time on this next point, but incentives matter. I think it was, was it Lindy that talked about the budget incentives and the pay that the legislators don't get paid if they don't pass a budget on time, right? Performance incentives matter. Now you don't want to incent, you don't want to incent the wrong things, right? More bills passed, you get high, right? You have to be careful about how you use them. But right now we have pretty weak incentives, I would say, for our managed care plans to improve their performance. We have an auto assignment program that rewards plans that perform better. Those plans that are in counties where there's more than one plan, they get a higher share of the people who don't choose a plan themselves if they're a higher quality plan. Frankly, that's something that the Healthcare Foundation partnered with DHCS in creating, and sadly, I would say I'm disappointed that it hasn't had the intended impact. That when we look at those quality measures that are rewarded through that auto assignment plan, those aren't improving any faster than other quality measures. So I think it really does come down to, can we add financial incentives into the program in a much stronger way? When you look around at other states, a number of states have adopted various ways of incenting their plans through financial incentives to improve performance, and that would be a tool that I think California really needs to jump into, and I can talk more about that if there's time.
Great. I'd love to bring Jen in on this point. And kind of circling back to the idea of variation geographically or among beneficiaries, which data points do you look at, like really jump out to you and are really troubling to you? And then what levers do you feel like the department or other folks have to really get in and try to address them? Chris mentioned a couple. Do you agree, or would you amend that list at all?
I think, it's more complicated. Like I mentioned, the dental issue, in that we are just now with 4 years of concerted effort in that program, and multiple funding changes also in terms of the legislature repealed the 10% provider rate reduction. There was the DTI funding, and then there's been Prop 56, which the importance of that fund source can't be understated in the overall program. And then you take the changes that we made to the application, the changes that we have done internally, and that was a 4-year process. Anything that you do in Medi-Cal, you really have to take the long view. So if you don't know me, I'm a marathon runner by historical trade. I am not a sprinter. So I think that better suits someone working in this program, which is, if you've ever started a marathon, there's always the people that are kind of bouncing around you, and they're like, I'm going to kill this thing. And you're like, that's awesome. And they hit the start line, and they're just balls to the wall. They're going as fast as they possibly can. And you're like, that's going to last for about, a mile. And you got 25 more to go. And then there's me who's lets everybody go. I just pluck away, and then at about mile 10 or 11 there's people on the side of the road, and then by 18 people are crying, and you're like, I'm still going. So when you talk about changes to the Medi-Cal program, I'm built for the long haul course. But I think we have incentives, we have contract abilities, right, that are pretty strong. Sometimes we use our contract power for good, and sometimes we have to use it, unfortunately, when people behave badly. So there was an unfortunate case last year where we had some sub-layer providers that were doing really inappropriate things, and so we had to order a number of our plans to sever contracts with them. And then we did a lot of unfortunate things in addition to that. And so, but the power of our contract gives us that ability. We can approve any subcontracted relationship with our direct plans. We can terminate the contract with the plan itself if we need to. Obviously, we've never had to do that. We've started sanctions and penalties. So we have done a really big penalty for a plan that shall remain unnamed for encounter data violations. We have sanctioned 2 plans for quality performance issues. I would say that we are just getting started, which is one way to do it. But I think there are positives that go along with that. So when you're running a program like this, is you can't rely on all negative types of reinforcement, and you can't rely on all positive as well. So we try very hard to kind of do a blend. And so on the Prop 56 stuff in general, those incentives, especially in the managed care program, are done through Lindy's area, known as directed payments. And so the plans are getting the money to incentivize certain behaviors, but they don't actually get to keep the money. It's a directed payment that goes to the providers providing those services. And so you will see probably a lot more of this in our overall program build, which is how do we incentivize providers at the level that we need them to make sure that beneficiaries are getting either the right kind of services, or are they increasing or improving their performance. We've got a value-based purchasing proposal in this year's governor's budget that is really trying to get to this more innovative way of looking at providers and saying, if you can do better in terms of increasing your individual metrics within the program around certain key areas that we've identified, the plan will be providing that value-based arrangement to you in terms of very specific tangential incentives. But those are all kind of big things that take a lot of time, and sometimes you just have to have the patience to kind of bear it out because they're multi-year types of initiatives. A provider can't increase their performance in a single year. And I also think that we, before I stop ranting on this, to really turn the tide in improving the quality in our program, it can't be like a one and done type of approach. And so I think we're also trying to be really mindful and thoughtful that we don't have providers moving, on a year-to-year basis. Like, 1 year we're going to tell them that we really care about cervical cancer screenings, which are important, and then the next year say, but we really care about, hypertension, and then next year we're going to do diabetes, and then we're going to do, and so we're trying also to be very thoughtful and looking most broadly at what are the populations that we have the most concern, and how do we find those right metrics to approach that. We know who our most expensive populations are in our program. They are, by and large, mentally ill. They have substance use disorders. They're more than likely not homeless. And then they usually have 5 to 10 other types of health conditions. And CHCF actually did a really great presentation several years ago around high-cost users that worked with our data analytics folks. I use that every so often where I go and I pull data out of that. And those are kind of the people that I think about when I try to design programs, which are how are we getting at the nature of those issues and really kind of trying to put some system changes in that better address those concerns. That's
great. I'll open it up to the audience in just a second here, but I want to drill down with Chris just for one more minute on planned financial incentives, which both you and Jennifer touched on. Can you talk a little bit about, again, Lindy spoke to this and Jennifer reiterated it a little bit, but can you talk a little bit about capitation-based payment and the potential challenges with that and the ways that that may be reformed in the coming years?
Sure. So, one of the things that we hear a lot about is and observe in the Medi-Cal program is the concerns about what's called premium slide, which is if you're a health plan that's doing the right thing, you're improving quality, maybe you're investing in services that aren't covered by Medi-Cal as a way to improve the health outcomes of your population, whether it be housing supports or additional transportation services or meals, or more you've invested into your workforce or better data systems to share data with the county behavioral health system. You do all that, you improve quality, and you drive down costs. The way the current rate setting system works is when your rates are next set, sort of 2 years hence, because there's a sort of a 2-year build-up to those rates, those cost savings are taken out of your rates. So you don't have that money to reinvest anymore. And in working with a work group of health plan advisors and some national consultants, we came up with one approach to address this issue, a premium slide, which again would address this so that plans could make those investments and share in some of the savings that they could then reinvest. Now, a couple of things that we were concerned about, which is, boy, if plans know that they can share in savings, would they do that at the cost of quality? How do we know that they're going to actually make those investments in those health-related investments? And so elements of this proposal, this gain-sharing proposal, would address both of those. They would say to the plans, first, of course, there has to be savings to share. Otherwise, there's nothing to benefit from. Once you've passed that threshold, you have to meet certain quality standards. And those quality standards aren't about meeting minimums. They really are about getting more aspirational. So I think one of the things that I would say in sort of driving Medi-Cal forward is that I think we manage Medi-Cal a little bit too much to the floors. We heard about the sort of the 25th percentile and the corrective action plans. I would like to see us manage Medi-Cal more toward improvement over time. We see, for example, of the 41 external accountability set measures, quality measures, consumer assessment measures, over the last decade, there's been improvement in only 16 of those. So I think we can do better, and I think 10 is a long enough view to say, this isn't working, let's try some new things. So this proposal would address the premium slide issue. It would incorporate a strong incentives to improve quality over time, and there would be elements to ensure that health plans are making those health-related investments. It can't just be by happenstance that they get quality savings and cost improvements. So that's one approach. There are other approaches to performance incentives. As I said, other states do it in different ways. We tried to come up with an approach that wasn't requiring new general fund spending, which was sort of one of the limitations that we were asked to work within. But a number of other states do it differently. Some without general fund spending, some New York actually putting money on the table, saying this is important enough to us that we're going to put some general fund money toward quality improvement.
I do want to give the audience a chance to jump in here. If you do have a question for one of our panelists, please just raise your hand, and Karen and Crystal will come around. While you're formulating your questions, I can't help myself. I gotta return to one on finance. One of the issues that we heard Lindy speak to this morning was provider payment rates. What do we know about the relationship between Medi-Cal payment rates and one of the issues that Chris raised up front, which is access to care? And what sort of data do we have right now about whether that's a problem or not?
I think that, I go to every meeting, hearing, discussion, and people say, well, if you just paid more, you could do all kinds of things. And I'm like, well, that's really easy, simple, but it's not that simple. It's interesting we're heading into our third year of Proposition 56, significant new funding source primarily for physician and dental services. And last year, when all was said and done, there was about $220 million that was left over in that year, and we put it into a loan repayment program that we're really excited about, which is a complete different tangent, but something either takes longer for physicians to recognize. I think there's a lot of different answers for that. It's not just as simple as saying, here's money and we want you to do more with it. There's some physicians that don't want to take Medi-Cal, period, and we can't bring them to that no matter what we do. And so I think there's always a limit, and this was certainly some of the conversation around Prop 56, which is, are you going to pay people more money to do the same thing? And that's certainly not what we're interested in doing. If I'm going to pay more to a provider, no matter which provider it is, I not only want them to do what they're doing for me today, I want them to do it better, or I want them to do more of that better for more people. It's not just enough to say, I'm just going to pay you to keep the same level of care that may or may not be that high of a quality for the same number of people, and that's just not acceptable to us. So we're never going to say as a department that it's good policy to just dump more money in to get the same thing. So I think a lot of our financing and access work has really looked at, where do we actually think there are access problems? And then we look at the provider capacity and we say, do we think that this is a combination of reimbursement? Certainly when we looked at the HIV AIDS waiver agencies, when we gave them some very specific targeted Prop 56 investment at the very first year, we only had 6 agencies in the state, and they were in significant financial distress, and the change of that small investment has really stabilized that program. So you could say that that was very much tied to the attrition of the financing support. But then there's others like, the physician and dental services. Is we put significant money on there, and it didn't necessarily change the utilization all that much. And so there's a lot of other things that we can do as a state in terms of administrative issues or, other types of incentives that we're really trying to play with in terms of like the loan repayment. These are loans for physicians and dentists. Within recent graduation, we're willing to pay up to $300,000 in loans if they give us a 5-year commitment, take a third of their population overall in Medi-Cal. And really what this is premised on is that we are trying to change the nature of someone's decision when they get out of either medical or dental school, that they don't feel that they can work in a safety net program because they need to pay off really crippling student debt. And so we're basically saying we think that we're going to change the nature of people's decisions such that we will take that off the table and we will embed you in a program, and you will be able to be successful there because we took away a consideration that is otherwise impacting people's ability to do that. And then obviously, because it is a Medi-Cal focused loan repayment program, we are really trying to generate an entirely new type of provider that is born and bred in the program, meaning they are here and they are here to stay. It's not just a 5-year commitment. And so that's something that is really kind of long-range vision for us.
How exciting. We do want to get started. Karen, why don't you go ahead?
Hi. I really appreciate the discussion today, and I especially appreciate the discussion about quality of care. So earlier there was a speaker that talked about Medi-Cal having lots of actionable data. There was another speaker that talked about a list of carved out benefits, and there was a lot of them. I wasn't familiar with all of them. But what I think about is sometimes quality of care can be improved with data, not really just money, but data. So I'm wondering, for beneficiaries that are using some of those carved out benefits, the transplants, the mental health, is that data shared with the health plan that member is associated with so that the health plan has the opportunity to manage that member's care holistically?
The simple answer is yes. So we feed data back to the plans on carved out pharmaceuticals, for example, for organ transplants. Certainly a lot of the work that we just did around the whole child model. So these are CCS kids in the county organized health systems where we have been putting those carved out CCS services back into the county organized health system. All of that data that has been happening in the CCS program, which is a fee-for-service carved-out program, has been fed back to the plan before they get the child so that they can see what kind of services and the nature and scope and type. But we do provide data feeds back to the plans for carved-out benefits. I can't say that all of them use the data, I can't say that the plans would say that we maybe don't give it to them fast enough. So I think those are a couple of fair points both on our end to make sure that the plans should be using the data, and then if we can get it to them in a more rapid manner, we will certainly try. That's certainly part of the conversation around the pharmacy carve-out proposal that we have, that we're looking for a January 2021 implementation date by, is that how fast can we get the prescription pharmacy data back to the plans?
Great. Crystal?
Thanks for the discussion. My question is about incentives that you were discussing, and I was wondering if you could compare incentives for Medi-Cal to Medicare and where sort of the Medicare program is heading with MSSP, where there's upside and downside risks for providers, and then also with MACRA, which I believe doesn't include Medi-Cal. Why the divergence, and do you see any of those programs or types of programs moving into the Medi-Cal arena?
We don't spend a ton of time as a department looking over our shoulder on the Medicare side, probably just, to be honest, just sheer capacity, right? If I spend all my time kind of looking over my shoulder saying, oh, what's the Medicare program doing? I'd probably crash my car off the side of the road. I think we have dual eligibles that we have put a lot of concerted effort into through Cal Medi-Connect and the duals demonstration, where that is kind of our state's effort to try to better understand what's happening on the Medicare side, as well as try to closer align the care from both those two very, very different delivery systems, because we don't have any, we have to petition the federal government for Medicare data ourselves. So it's really hard for us to kind of look at a different program that is wholly financed by the federal government, that is run by a different set of rules, and is actually administered through a different arm of the CMS, for us to kind of do a lot of work in that area. I think that we look at some of the dual special needs plans, and some of those areas where we kind of look and say, is there something here that we can kind of glean? Is there a best practice? Is there an interesting benefit? Certain things like that, where we will study it and then look to see if we can incorporate it. But it really does get down to the financing of how that is, in terms of, we have a state share. The federal government, obviously is 100% supporting the Medicare program. So I think as we look at this, kind of the aging, the long-term aging and plan that the governor's recently said that he wants, that's certainly an opportunity for us as a state to kind of revisit some of our previous thoughts on whether Medicare has, certain things that we would want to take from it. But, because we wrap everything around on the Medicare side, long-term care, home and community-based services, IHSS, for example, we as a state have actually spent some time doing those supportive services, but not really trying to understand the Medicare benefit, kind of broadly writ as it pertains to hospital and physician services.
I think a couple things just in observing the Medicare market and the commercial market that we can take away from some of their experiences in risk sharing and in performance incentives. One is that particularly when we're talking about at the provider level, we have to be very cognizant of differences in patient populations. We have to make sure we're not just rewarding the haves and giving the haves even more resources and starving the have-nots. Some practices are more resource thin. We want to elevate them as well. And if we're just rewarding the highest performers, which is, I think, where some of this started off at, we realized that we're missing a big share of the market, and really probably the market that needs the help the most. And I think the second is that the incentives themselves are not enough, that there has to be an investment in the kinds of delivery system transformations that are needed to succeed under performance or value-based payments. As we look around, whether it's the public hospitals that have a an incentive program under Prime. When we do a lot of work with federally qualified health centers. There are some that are ready to embrace value-based payment and have already started investing in team-based care and integration of behavioral health and all the things that are necessary to manage population health, reach out in the community, stratify their populations, who's not coming through our doors, who do we need to serve. But there's a vast majority of those clinics that aren't ready for it. And we really do need to invest in them to develop the capability so that they can succeed under these kinds of incentive payments.
Chris and Jen, one of the questions that comment stimulates for me is alignment, and there's alignment of financial incentives, and then there's alignment of quality measures. So when we look in other markets, we look in Medicare, you've got the quality measures that are tied to MIPS. If you look in the commercial market, you've got the AHIP core measure, collaborative, and other things. The big simple idea here is make it easier and measure and reward the same thing. Just again on kind of a 101 Medi-Cal overview, Medi-Cal explained kind of theme of the day, is there one set of measures that all Medi-Cal health plans are monitoring and reporting back? And if not, are there efforts now in the state to get there?
So we do have metrics that all the plans have to report to us in terms of the core set, and then those in turn are reported to the federal government. And we, I can't remember what the number is off the top because it's both pediatric and adult core set measures, some of which are easier to actually measure because it's administrative data that we can grab pretty easy, as opposed to like a hybrid measure, which is a combination of administrative and kind of qualitative data from the provider itself. I think that the thing I would say around the Medicare like star rating in particular, I know that the D-SNP plans in particular have always felt that, and I can't remember if it's changed or not, they were held to the same kind of measurements that the Medicare Advantage plans were, but they have a much different population. To Chris's point, is those are dual eligibles who automatically, by the nature of their low income status, and this is just from a data standpoint, they come to the program with poor health and obviously poor health outcomes. And so if you are asking two plans serving populations and holding them accountable from a financial standpoint to the same measure, but one plan is able to kind of stream out either risk, or they don't ever have that risk hit their door in the first place, right? They're just doing some hip and knee replacements. People are generally healthy, whereas in the dual eligible population, if they have been dual eligible for a long time, it's because they have a long-standing disability. Sometimes that's a mental illness. You look at the survival rates of people with schizophrenia who live 20 years less than other populations. Those are very kind of concrete pieces of data that we all want to change, that we're all trying to change. But when you talk about plans and measurements, one plan that does the right thing and has those populations, and they're trying really hard to change the nature of those quality scores, and then you have a plan that does not have that population and they're held to the same standard, you have to ask yourself from a policy standpoint, is that the right way to go? So I think, again, we've done some thinking as a state about this, but I think we're always looking to better understand what are our biggest pain points in our program in terms of populations where we want to see better outcomes, and then you just have to put yourself in the long view of making that trajectory change. I think we would point with pride to the work that we've done with CHCF and the Department of Public Health and the California Maternal Quality Care Collaborative. The CC is always the last piece, where the rest of the state, infant mortality and morbidity and poor birth outcomes has been, going up, and that's not a good thing. And in California, it's doing the exact opposite, and I think we're really proud of that. But then when you kind of pull that data back and you say, is that for all populations? In our state, that's actually not. And so African American population has much more poor birth outcomes. And so even within our own state, we're going to be grappling with the fact of how do we change that outcome and that quality metric. And so these are the kinds of things that, again, lots of work gets done. The data is there. It's just more that you're changing the delivery system, which means you have to change provider behavior, which is a much harder thing to do on a macro level.
Good. Well, we have just about 5 minutes left or so. If we have time for maybe one or two more questions from the audience, if there are any.
Hi, my name's Kathy Arbanis, and I'm a Medicaid beneficiary. And I guess, in this whole person care thing, is there any, are there any plans to try to do preventative measures to keep people from being homeless? Like, not necessarily, I know that money is a big problem and things can cost a lot, but even in promoting legislation to help people who are disabled, be able to retain their homes, or if you're on old-fashioned Medicaid like I am, I'm still, subject to asset limits. And if you own a home and you have only $2,000 of assets that you can have, if you need to do a major repair, you can't do it. And you can't get loans very easily when you don't have very much income and you don't have very much in assets either. That makes it very hard to continue to live in a home that is healthy to live in. And it just seems like preventative healthcare measures are really important too. But if you're looking at everything that affects health, that there are things that can be done to prevent those things as well. And is there any talk of collaborating with other agencies or with legislators to make laws, or even to pointing beneficiaries out to resources that can really help? I mean, sometimes when they say that there are things places that you can go to get help, you're led down a path of a dead end where it's all like somebody's got a page or something that says donate on it, and they don't really do anything to help people. So that's kind of like the question that I have, right? And in relation to that, it's like crowdfunding sources or ways that people help people like me sometimes, like GoFundMe sites and stuff. And one thing I've run into recently is that one of my friends set up a GoFundMe site to help me with my roof. And now I'm in the middle of a Social Security redetermination, and because I found out I had resources that I could spend down, and I did what I was supposed to do, and I'm going through hell with them over it. But through that, they found out about my GoFundMe site that my friend set up for me, and that may end up, I haven't looked at the numbers, lead me to have to pay them back, or ask them, or have them ask me to pay back more than what my friends raised for me. And do people think about these sorts of things? I mean, Medi-Cal patients need to have more awareness of how these things can affect them.
Yeah, so that's a great question. So I think the thing that we have done most notably in the last few years was around the 1115 waiver around whole person care. So this was the state's first effort to get into the area of recognizing that individuals have a lot of other needs, not just medical, but social needs, and specifically around housing. And so Medicaid, longstanding policy with the federal government that they do not pay for housing, they do not pay for room and board. But what we did in our waiver and whole person care was we said we're going to do these pilots, and for the first time we're allowed to have counties in these areas using funding to help do supportive housing. And so we still can't pay for rent, but we can do tenancy services, we can do supportive housing elements. So if we are having people that are having housing challenges, these counties have been working across different agencies, including their local housing agencies, to help people find Section 8 housing, to secure housing if they have otherwise been homeless. So thinking about there's housing pools in which they can help people do first and last month's rent, things like that. It has been successful, and I think what you see in California is a struggle because we are such a high-cost state that counties are like, we are doing what we can, but even that is not enough to kind of get people into a supportive house because rent is just so much more significant. You will see in the governor's budget this year that there was a $100 million augmentation in our whole person care pilots, specifically around housing, and I think that was certainly in recognition of the fact that we have counties that are doing the right thing, trying really hard to find places that are stable and secure for individuals. because there's also a recognition that until you have a stable housing situation, you can't be expected to also maintain other types of health services or behavioral health services. And so we as a state have done some. It's not enough, but I think we are well on our way to kind of helping try to also have these local governmental agencies work in collaboration with each other as opposed to being in silos, which has certainly historically been the problem.
It's terrific. Well, we are coming to the top of the hour. We've been together for 4 hours, which is kind of hard to believe. It's just flown by, for me anyways. But 3 things before we let you go. Number 1, I do want to remind you that there is a bunch of new resources in the packet that you have in front of you. It's available on our website at chcf.org/mc-explained. We've worked with a number of folks to try to provide you the basics in some areas. And so I do hope you'll take that and use it in your work. The second thing is Sandra mentioned this at the beginning, there's a green or yellow evaluation sheet in your packet. We really do take a look at these things, and given that we're launching a new series, we really want to hear from all of you, the community, on what topics you would like to have us produce material on and host briefings like this about. And then the last and final thing is please join me in giving our panelists, Jennifer and Chris, a hand, and all the panelists today. Thank you very much, everybody.